Our next session is entitled The Future of Value-Based Care and the Emerging Importance of Health Equity. And we have some very esteemed guests today to give some of their perspectives. And I'm gonna give y'all just a minute. If y'all would do, just introduce yourselves, and we'll start with Jonathan, and just 1 minute of your background, and then we'll get started.
Thanks. I'm Dr. Jonathan Fialkow from Baptist Health. I'm actually a cardiologist and specialist, and I do think there's a role for specialists to be successful in primary care. I lead our cardiology division at our Cardiovascular Institute, so I also am familiar with the Institute Center of Excellence model. But for part of the purposes of being here, I'm the Chief Population Health Officer, so I lead a lot of our value-based strategies in the Baptist Health System. Thank you.
Hello, everybody. So my name is Frank Exposito. I'm the president of American Choice Healthcare. I've been running ACOs for about 10 years now, and have seen the model grow and change and flex over that period, which obviously some of your panelists have already mentioned. So I'm excited to talk to you a little bit about our experience and what we've seen have been pivotal changes within the model that's going to benefit the future of Medicare fee-for-service.
I'm Peter Young, Healthcare Strategic Issues. I believe I am the senior member of the group chronologically, and so I know where the skeletons are buried, and I know the path out of the graveyard, and we'll talk about that.
He may be the senior, although I'm not sure. But the fact is that I'm Mike Segal. You've seen me around here all day. I was just noticing, I just want to say in passing, my friend Paul over here, he must be my bibliographer. He brought stuff that I've done in the past, and he brought me this big outline from June 24, 2010 that I gave at the Palm Beach County Medical Society, entitled Accountable Care and Clinical Integration, an Evolution to Healthcare in Healthcare Delivery. So you can see this has been ongoing for a long, long time. So well, I hope we have a chance to talk about this.
Mike, before you stop, open that page and read it, that one.
Yes, I quoted from the March 26, 2010 issue of the New York Times, in which they said, a quiet revolution is transforming how medical care is delivered in this country. And it has very little to do with the sweeping healthcare legislation that President Obama just signed into law. Remember that? But it could have a big impact on that law's chance of success. So part of what we'll be talking about today is, was it successful? And how long do we have to go if it hasn't been quite successful for it to be successful?
Okay, thank you. So we'll go down the line here, and we'll start with Jonathan, but give us from your perspective in your business, what you see as the future of value-based care, and we also want to touch on the importance of this new theme about health equity too.
Thanks. So that's obviously a broad question, and everyone here could probably spend a couple of days answering their own vision of what they think about the future of value-based care. I'm heavily into value-based care in my role in the system. A lot of it came back towards being a preventative cardiologist and seeing, people with the disease conditions that led to costly outcomes. When we built our cardiology group, which was a private group, we were acquired by the system 5 years ago, and Mike was an instrumental component of that. We did not build on the group of just putting a lot of doctors together and driving higher reimbursement rates. We actually started working with the payers about value before they even knew what value was. 2006, 2007. We can provide better access for your patients. We'll use appropriate use criteria. We'll see the people in the ear and we'll kick them out. And a lot of the payers didn't even know what we were talking about, but that was always my mindset. So having said that, being inside of a health system now, and a multi-billion-dollar health system with strong, probably the highest commercial rates in the country, Mike. I mean, I think, their Baptist is the 800-pound gorilla. It's an interesting perspective. So obviously value-based care is here in the future, and we know that the majority of patients in the country will be in some kind of value-based arrangement, even if it's not with the actual, even if the hospital's not the value-based arrangement, the patient coming in the hospital, someone's managing them. I do think there'll be certain fee-for-service hybrid models, so I don't think it's going to be exclusive. But the reality is, when we look at our demographics, aging population, more diabetics, all those diabetics leading to worse disease, outcomes, the need for a multidisciplinary approach to those patients can only really be done with value. It's not just primary care, and I'm a strong primary care advocate. Some primary care deliverers are more robust and integrated than others. You need endocrinology, you need cardiology, you need behavioral health specialists, you need exercise physiologists and nutritionists. We need to really get into all those components. So from the standpoint of value-based care, while we can manage a lot of populations without a health system and without a hospital, right now I see, at least in our area, the scale, the money, the infrastructure necessary for managing these patients requires kind of the big structures of health systems. And the hospital is a part of that. And I'll just add as a last component, not to go on, the reason for that, and this goes back to health equities again, is when I look at our space and the catchment areas and the patient populations and the spends and the costs, it remains access. We can spin it any other way we want. We can talk about generic utilizations. We can talk about A1Cs being controlled. We can talk about whatever quality parameter we want. But if the individual does not have access to healthcare, then we fail. And access to healthcare, as we all know, it's not just an appointment with a doctor. The average age of a doctor is 55, 25% of our healthcare providers are over 66. It's got to be about teams. It's got to be about getting to the patient where they are, home visits, devices, monitors, apps that wake up in the morning, how you feeling, and alerts if there's a problem. All those things have to be put together into one model to get the people where they are. And I just think the scale of that right now, it's costly. The infrastructure is necessary. The strategy is there. The execution has to be very thought out and robust, because otherwise you're doing anecdotal experiences. And at least down here, I think the value proposition, which is ultimately how most of our patients will be managed in some ways, will include healthcare systems, whether you those that are involved like it or not. Now, hospitals are a different story. They're part of a healthcare system, but I think the scale down here anyway would require healthcare systems. Hopefully that's able to give some perspective.
No, that helps. Thank you.
Whether you guys agree or not. Access.
And Frank, if you could tell us about your experience in business in the ACO world and the direct contracting entity, and now getting ready to embark on the ACO REACH program.
Sure. So I definitely agree with Dr. Fialkow here on access. I think that's one of the things that we see is the most difficult to control and really kind of embolden within the market. Obviously, we come in as sort of an administrative support to our practices, and we kind of see where are the areas of, that are being obviously sort of dictated by the data and obviously clinically reviewed that are operationally weak within that practice. We work predominantly with affiliate practices. So we tend to really look at really a concierge level tailored approach to what the experience of that practice is having that impedes their ability to either improve access, improve quality of care with their patient population that they're trying to manage, particularly within these, obviously value-based contracts that reward increased sort of management on their patients. So when we look at an individual practice, we're really helping them to assess what are the access points, the frequency of access that provider is having really inefficiently with the rest of the market. We've mentioned this before in this conference already about primary care physicians being on the bottom of the totem pole and obviously trying to rise them up. I would say in our experience, they're not at the top. It does take a lot of effort in order to get them there. I think that's what the industry is trying to push for, and it does require a lot of enlightenment and control where they haven't had that before. So one of the abilities to really break the market apart a bit to defer back to the primary care physician is, I think, one of the main goals that we've had that we've actually been very successful in. Is to really sort of demonstrating that they do have power, that they do have the ability to impact their patients' choices with influential ideas of what's best for their ultimate health. And when you are reacting to a market that hasn't had that type of infiltrator or that director, you do rub against systems and facilities that have notoriously had that control. So over time, what we've seen is that we've seen providers get very comfortable with data. I think that's one of the first things that they never really had. Even if they were in Medicare Advantage plans, the data that is out there that's effective for this program is very different. It's very actionable. It's not really that financially driven. It's much more qualitative and outcomes driven. And when they get comfortable with that data, they can then make better choices, and they can really look at the market and assess their referral patterns, who they are sort of really bringing onto their team to help manage that patient. The primary care physician doesn't do at all. Of course, there's a whole entire system in place there to take care of that patient. But being able to really assess where the patient should be going and who should be seeing that patient, and making sure that the physician is always aware of that level of communication is key. It's a glue that's been missing and I think has been evolving over the last 10 years. When we look at the future, as is the subject of this panel, I think that's where you're going to see the market continue to shift in the primary care physician's favor. More innovation is going to allow the physician to be in more and more control. And I think that's something that we innovate quite a bit with our team and the way that we approach the model. And we're obviously looking forward to consistently looking at the best of breed technologies, the developments that we do from a technology side to deploy to the practices to fill in those gaps that ultimately help the physician be smarter about what's happening outside of their four walls, which is until 10 years ago really wasn't accessible to them. And then now obviously pivoting a little bit into health equity, which I think is an interesting part of this panel. We've been operating under sort of 10 years without health equity. We've been looking at the data without really looking at sort of disparaging sort of impacts based off of race or other qualifiers that have been brought forward. So it's interesting because the data that's still present within the model is specific to the data the way it's always been. It's claims-based data. It's not data that now includes this information. CMS is actually asking us now to be the inquirers of this information. So when we have a patient that's out there, they want us to basically ask that patient how do they identify race, sexual preference, et cetera. So that's going to be an interesting, I think, experiment, because the way that we've always approached underserved communities is really looking at the areas where the benchmarks and the expenses don't make sense, right? There's not a cohesive view on the way that the expenses are correlating with what CMS expects that budget to be within that area or neighborhood. So we've always been able to identify what are underserved communities based off of excessive costs. We look at excessive costs as poor outcomes, right? If a patient is going constantly back into a readmission state at a hospital, or they're seeing 8 different cardiologists, not to say anything about cardiology, but you know what I mean.
Whatever you say, we deserve.
Yeah. That's ineffective, and it obviously doesn't improve the patient's outcome. And it's because there isn't that level of clarity that's being sort of transmitted down to the stakeholders that can make those decisions better. So I'm interested to see how that experiment works out. But I would say historically, we've always really targeted underserved communities based off of what the data is. And then, of course, collaborating with the clinicians that would tell us, obviously, very clearly what their experience is with those patients. Thank you.
Okay, thank you. Peter, what perspectives can you add about what you see as your in your business in terms of
my
the future?
crystal ball,
That's right.
Walmart. And I think it's important to note that Walmart is going to open 23 clinical operations here in Florida, but they're going to have 3 in one city, and that's important. Does anyone know what city that is? No, no. Jacksonville. And who is the biggest book of business for every provider in the state of Florida? Florida Blue. They are going to redesign, they're not going to redesign healthcare. They're going to wipe healthcare as we know it off the board. And they're going to bring it back up in the way that they've had 3 decades of experience as the largest commercial payer in the United States. And they're going to niche carve it out. There's not a heart that's done in Florida if you're a Walmart employee. You're going to Cleveland. There's not an orthopedic procedure that's done. So what they've done, and the word is analytics, Walmart and analytics is the second takeaway. Analytics drives everything. We're going to know, and we already know today, every physician's clinical performance by cost, utilization, and outcome. So one of the things that we need to be thinking about is, are we using the same system to get the data? Are my outcomes being compared by the same type of analytical capability? Because that's what's going to design the networks of the future. And this ought to scare, I feel like sending some of my hospital clients boxes of Depends, because it ought to scare the out of them about the way the change that's going to happen to value, where primary care does do the flip and it brings the specialists along, because the specialists in the peer-to-peer evaluation, suddenly it's not just South Miami Orthopedic Group as an example, but it's the doctors that comprise that group, where the analytics tell me that I want to have Dr. A and Dr. C in our network, the Walmart network, or we want to leave out Dr. B. So in the future, we'll have 3 major network operators. That's the access point. Access. Walmart, they have the retail footprint. All primary care will move to retail type settings. CVS, Walgreens, they'll be the 3 big footprint operators. CVS made a big change to signify where the future is going in avoiding hospital care to the home. And they're closing down their long-term care nursing, skilled nursing facility, all that pharmaceutical business. Their number 2 volume driver for their business. They're going to sell it off. They're buying Signify Health, which is a large home healthcare provider with a great analytics platform. So you begin to see that the future is not hospital beds and heads in beds, but keeping heads at home in beds, keeping people out of hospitals. And I have a basic industry criticism, is that when you look at readmission rates, that's a reflection of the quality of healthcare that's being practiced within the community. So when we see higher readmission rates, we have to start asking, what can we do to change that? How do we put the incentive out there? And that's what CVS is doing with value care. And I'll shut up for a minute now.
Okay, Mike.
I gotta follow that?
You got to top that.
It's on page 10. You said it 10 years ago.
You can tell a joke if you want. You can lighten it up.
You got a specific question or should I just talk?
I think from your perspective, what the ACO REACH program and the future of ACO REACH and health equity.
Okay, yes, we've been doing a lot of work here in the ACO REACH space. And in that case situation, we have to basically focus on health equity because it's an important part of the new ACO REACH model. This is somewhat political, I think, because the fact is that the idea of health equity is basically finding out from people who have not had sufficient health care, not treated, because a lot of times they don't even show up. What's wrong with them? How can we fix it? I have a quote here from the director of CMS, who says, when we talk about health equity, we mean everyone having a fair and just opportunity to attain their optimal health, regardless of their race, ethnicity, geography, language, socioeconomic status, gender identity, sexual orientation, the myriad factors to go into being able to access healthcare, and the myriad factors that impact someone's health. That really is central to everything we do in our program for our day-to-day operations, making sure that care is navigable, that people can understand what their options are, that they can access what they need. Now, that's from the director of CMS. The ACO REACH program, believe it or not, nobody's actually signed a final contract. None of these new ACO REACH entities or the DCEs that are transitioning into ACO REACH have signed a final contract. That's because there isn't one. The final contract is supposed to be available on or about December the 1st. And why is it taking so long? Because it's mostly about drafting the stuff about health equity. And the government really wasn't quite ready to put it out yet. They probably still aren't ready to put it out yet. They probably won't be entirely ready to put it out yet when it gets out on December the 1st. Now, once it gets out on December the 1st, you have to sign these contracts within about 2 weeks. And if you don't sign the contract, everyone's going to sign the contract. So, this is only the first play, because I don't know how many of you saw it, but Tuesday night, the government issued their 2023 final fee schedule for next year. And in there is stuff about health equity and how they're going to start using that as a criteria and how much they pay you. This is going to keep going on and on for a while. Now, if there's a change in parties in 2024, they may reassess it somewhat, because this is more of a Democratic program than a Republican program. But from what I've seen in the past, once this stuff is in there enough, it's not going to get taken out. It's there, and it will continue to be worked on. So I don't expect it's going to be going away. And the idea is simply, but if you have to be assessed on health equity, and you have to focus on getting more people in underserved communities to be in your ACO, because the concept is that people who are in underserved communities have not had the same access to be in an ACO. People don't want them in an ACO because they're afraid. They haven't been seeing a doctor, so their average costs are low. And once you start sending them places and getting them health care, it's going to go up, and that's going to kill your ACO, because you're trying to reduce costs, not increase costs. This is a big experiment, and it's going to be, I guarantee you, what they put in at the beginning is going to have to be changed, because they don't know for sure what they're doing. They're going to, CMS is going to increase, give you a break and increase the amount, your base, your benchmark, with health equity people, to give you a break, but they're taking it from the other side. A whole lot of details. I'm not going to get granular tonight, but I will tell you that every single year, starting next year, an ACO REACH entity has to have a written health equity plan, and it's got to have data, and it's got to have it focused, and you've got to explain what you have and what you're doing to treat people and how it's working. And none of that is quite in writing yet. They tell you it's going to be, and it'll be very interesting. Come December 1, don't bother me for about a week, because I'm going to have to read this thing. And then we have to then go and amend all of our clients' participation agreements, because we didn't know what to put in about this. And once we do, we have to add it. So, and by the way, when you're speaking of the data and all these big companies, I saw last week that Apple announced that in 2024, they're going into the health insurance business. They're going to create a health insurance plan, and they have some formidable data. And what do you think that data is? These fancy watches, the Apple Watch. They've got tons and tons of data with respect to your blood pressure and all sorts of different stuff they get off that data, that Apple Watch makes them powerful from the very inception. So health equity is going to become a significant factor. I think when we started this business, when I wrote this thing back in 2010, I talked about the triple aim, because that's what the government called it. And the triple aim was that we're going to create a plan that reduced the cost of care, increased the quality of care for a specific group of people. Well, now it's at least a quadruple aim, because all of those things, plus we're going to focus on different qualities of people as to how we take care of them and improve the quality and find out about a population. And one more thing, then I'll be done. One of the waivers that they instituted with ACO REACH was nurse practitioners and being allowed them to do more than one thing. And Peter pointed this out to me in an email he sent to me the other day, that you can, under this waiver with the nurse practitioners, they can, it's not exactly home health, but you can go into someone's house after they've had surgery, and up to 9 times in a year. But when you go into their house, if you're worried about health equity, your nurse practitioner needs to be trained to take a good look at the house. What's on? Maybe they don't have an air conditioner, like Juliet was saying, in the floor where they're at. Maybe they don't have, maybe they don't have any food or hardly any food, or the food they do have is not healthy food. All sorts of things that they can check out during the time that they're making those visits. So a lot of little things.
Well,
Let me just follow up on what the other Mike said, is that what we're really seeing is the social determinants of healthcare getting a lot more weight. And when we look at how CMS is weighting this, all we have to do is look at the STARS program. And that's what I always have said for years. Ask your payer how you can help with the STARS. Then you begin to bring into the equation of the goal, what we as a provider need to do to help them improve their STAR scores, and ultimately it helps us improve our bottom line.
Well, one of the fascinating things in looking at the ACO REACH program and the applications for a request for applications is they go to great lengths to talk about the health equity, and they want, you know, the participants to have a plan, and they track data and they track outcomes with the objectives they create. And it's pretty clear from that is this is a pilot project so that CMS can learn what works and what doesn't work, and they're going to start embedding more of that in more of their programs. And I think Juliet gave a good example of a system that tried to discern why, when, you know, the temperatures were up, they had more admissions for COPD, and they found out there was a community that didn't have air conditioners. And so they solved that problem, and they solved the unnecessary admissions to the hospital. And I think the reality is this is sort of an incubator, the ACO REACH program, for them to get information and data on processes that may work that are social determinants of health. And that's fascinating for me because it seemed like for the last decade or so, we've been talking about evidence-based medicine and protocols and clinical integration and providers communicating, but this is like the other side of the coin. This is the things that are not directly related to the clinical care or protocols of, you know, what's going on in their environment or their understanding of what they ought to be doing. And that is another level of breaking the cost curve. And I guess, Frank, what challenges do you see with that? You know, you're getting ready to embark, switching from a direct contracting entity to a ACO REACH with this new requirement in hand.
Yeah, I mean, you know, I think the challenges are really based off of the data, right? You know, obviously one of the things that we mine consistently is how is the data, obviously sort of comparing expenses to benchmarks, risk scores, obviously in there. And when we're trying to qualify, you know, what is considered an underserved community, it's important for us to understand, according to what CMS also wants us to do, what the racial identities are for these individuals, et cetera. So we actually have to be, we're being requested to actually ask those questions in a survey format to those patients to then really understand, are we hitting exactly those metrics correctly for that, obviously healthcare disparity. So that's going to be a bit of a challenge. I think, we do our best work when we're really focused on supporting the primary care physician and their practice. And I think this might be a slight, impediment to that, because it does require you to become part surveyor at the same time sort of data gatherer as opposed to data miner. So that's going to be, I think, a change in the overall system of the ACOs and how they operate, obviously for their sort of primary care initiatives. But the other thing that I think is really sort of key to all of this is that, when we look at communities and when we look at all the claims information that's coming in for the patients that are managed by that ACO, we haven't always looked at it from a sort of neighborhood perspective, which I think is a positive step forward. And that's, I think, something that's going to be kind of sort of revolutionary to the way that at least we look at the data, really sort of narrowing down on what's happening in this zip code, what's happening within these few blocks, in this neighborhood that, could be very different experience of what's happening across the street somewhere else. So looking at it in that novel way, to us is exciting. And I think when we sort of continue to sort of stitch together what our action plan is and how we actually execute on that plan, I think that's going to be the most interesting way to sort of structuring the data and analyzing it productively for our primary care physicians. But ultimately, again, looking at underserved communities, is something I think the market hasn't done, because there's been this sort of really malfeasance on CMS's side with regards to benchmarks, right? How it's very difficult to incentivize outcomes and innovation in areas where you can't really either manage that population or the benchmarks are too low in order to manage that population. So I think this is starting to kind of test the waters on that. I mean, obviously there's new rules that just came out earlier this week that also are really testing the ideas of establishing much more stable benchmarking moving forward, that does sort of aggrandize the opportunity across the different states and different neighborhoods that ACOs don't necessarily exist with high levels of penetration. So in that instance, I think CMS is starting to kind of realize that the last 10 years we sort of disincentivized areas, and now they're looking at areas to sort of incentivize, which I think this is a good step forward.
What percentage of your clinical practices are Medicaid payer?
Medicaid.
Medicaid, yeah.
So yeah, I mean, most of them. So we're looking at a traditional affiliate practice that's not Medicare Advantage based. So we have a sort of a deep penetration Medicare fee for service with a much larger commercial population, and then sort of an equal
So if
sort
you
of
were
portion with
taking it on a
Medicaid.
pie chart, what would the pie chart look like?
It would be mostly from a patient volume perspective, commercial, then Medicare fee for service, then Medicaid.
Go ahead.
In terms of serving the underserved.
Yeah.
The FQHCs, that's what they've been doing for the last umpteen decades.
One time, yeah.
And how can we, I just had a contract with FQHC to run a PACE program. And we're very excited about the potential, like God. But it's really, FQHCs are very eager to do it, but how you get it done is another story.
Right.
Because historically, those FQHC patients, once they get a hold of a Medicare card, they disappear from the FQHC, and it's very hard to keep track.
Right. And I think that's been, the issue when you're looking at sort of Medicaid ACOs and other sort of obviously like programs that are dealing with that type of population. And it's all about incentives. If the incentives aren't there, it's difficult as a private industry to invest in those. So I think CMS is, trying to tool with the ability to incentivize participants in other areas, I don't think they've gone far enough. You know, when we're looking at, you know, specifically our population, I'm speaking to our population, there's a difference of about $30 on the benchmark. $30 is not going to help us manage a complex patient population that doesn't want to be managed, right? You know, we are talking about Medicare fee for service. This is an open network. There is a level of freedom that's installed within, you know, the culture of Medicare fee for service that, you know, you have to appreciate and you have to identify as being distinct to other payer types. So, you know, doubling that on top of it being a hard sort of population to manage to begin with, it doesn't equate financially to success. So, you know, I think if CMS wants to continue moving forward, I think this is a good illustrative step, but surely, you know, the economics are not there yet to get to a place where I think there will be this 100%, I think they said somewhere that they want 100% adoption by 2030, that every patient would be in by 2030. I don't think this does that. I think, again, this is a good step in that direction. You know, most likely you see a doubling probably from 20% to 40%, you know, over the next 10 years. But, you know, again, it's all about incentives. I think if you can look at, you know, what works well across, you know, sort of the traditional Medicare fee for service population and try to apply it to these areas, I think you may have success. But when you're looking at the levels of risk that, you know, private industries have to actually involve themselves in, where are they going to go? They're going to go to the most limited risk-based product, right? We talked a little bit about earlier about sort of stepping your toes into risk, right? There's limited risk contracts and they go all the way to 100% risk contracts. How are you going to do 100% risk contracts on a much riskier population, right? That's difficult, I think, for, you know, a market to swallow. And that's going to be, I think, where the rub is, you know, over the next 10 years to get there.
Okay. Jonathan, I may come back to you in terms of, you know, with the health system, what challenges do you see with the movement or the initiative to move towards value-based payments? And we've said it a couple of times in the room that a lot of times in value-based care, unnecessary admissions are a big thing that can be reduced. And obviously that hits hospitals directly, but what do you see as the pros and cons of this for health systems and hospitals?
Yeah, to our health system, when I speak to colleagues around the country, this might not be unique, but the Baptist health systems are busy. We have capacity problems. So if we're going to disrupt the demand for certain services, we'll backfill with something else. I guess this is what I try to work with our leaders about. We can be in the value space. Let's keep those who don't need to be in the hospital out of the hospital, and you'll still be busy. You'll still keep your volumes up for your high profit procedures and whatnot. And that's working, actually. We've shown them that, especially in the COVID environment. And we do have value-based arrangements. We have some risk arrangements with some Medicare Advantage payers, some shared savings with commercials. And we've been able to show them the performance in that space, and it did not negatively impact what were their bottom line performances. But again, a long way to go from that standpoint. I think the biggest obstacles would be, at least in our health system, Baptist Health, number one, builds around both these efforts. That's their strategic model. So not a big Medicaid population, not a big opportunity. Baptist Hospital, 900 beds. We had to drop out of BPCIA because we didn't have enough Medicare patients in the fee-for-service area to be able to support. That's a different model, a different mindset. Now, Baptist took on some hospitals in Palm Beach County with a heavy Medicare population. So now they're starting to open their eyes to how we manage those populations. But the biggest obstacles would be the leaders in our system have been hearing that the sky is falling and the cliff, you're going to fall off the cliff in value for 10, 12 years. And I was one of the ones that's been telling it to them 12 years ago, and it hasn't happened, which enables a complacency because we do know it's happening and it's going to happen. It enables a complacency. Our primary care group, which may go into a little shift into value, is built on feeding the beast, feeding the imaging centers and feeding the surgeries. Their report is how many referrals they make and how many images they order as a positive component of their performance as an employee. My head's exploding. I'm trying to bring a different perspective.
Well, that's not just you. That's across the country.
That's the model. So, this is the obstacle. Now, on the other hand, we're making good inroads. We're educating, we're showing the value. I want to comment on something made to these folks regarding something, because we're trying to change the dynamic in the care delivery model. I mentioned the team-based care around diseases. So, the idea you have to get the patient to a doctor, what we're doing is something relatively sophisticated, I think. We're trying to match the complicated component of a patient to the skill of the doctor. Let me see if I can articulate that. If you look at the patient population's medical illnesses as a bell-shaped curve, people are healthy, people have some really complex problems, and the majority, hypertension, diabetes, arthritis. But you look at the skill of a provider, it's the same thing. Doctors have certain levels of skill. The majority can handle things, but certain high-skilled doctors can handle complex conditions. The mismatch is if a referral is from a primary care doctor to their buddy, it might be for a complex condition that the buddy can't handle, and they don't see that, and then the patient's in the ER or on the wrong medications. So we're putting through a lot of methodologies with the referral patterns to make sure that we're getting the doctors who can handle those complex conditions, matching the patients. The other part of that is the team, the nurse practitioner, nurse navigator. Nurse navigators are critical in this space. I look at the data that Peter's mentioning. Now I'm talking, I sit with payers, I sit with primary care groups in my cardiology role, and in my pop health, because I lead the value-based, I'm also representing it. I could tell you that when you look at a lot of the data regarding the cost of your providers, it's not that great. It may resonate, but the detail does not support new care models. And if I can give 3 quick examples that came up in the last couple of weeks, just to show you. One was with a large payer, and we're going through our joint operating committee. Now, we've developed disease management programs. We have a lipid cardiometabolic clinic. So all patients with complex lipid disorders who can't be handled by primary care get referred to the clinic. Protocol driven, nurse practitioner, incredible outcome driven. We get the people at goal, which means quality metrics of primary care. And we also do it for high complex diabetics with cardiovascular conditions. 9% of the diabetics in the country with cardiovascular conditions are meeting their goals. So we manage it through our team. So the primary care doctors and the cardiologists are prohibited from ordering PCSK9 inhibitors. Are you familiar with these drugs? These are expensive lipid drugs. So we're meeting with the payer, and they're like, you've got a PA in your network who's really ordering a lot of these expensive medications. And I'm like, is that so-and-so? She says, yes. And she realizes she runs our lipid program. What you're not realizing is she's de-escalating 35% of the referrals off of those expensive drugs because we can get them on statins and generics. And the doctors who look like they're really high performing are not allowed to order those drugs. So their data is skewed when they look at who's high performing because they haven't caught up to the team-based model. Now, I'm going to give you one other example, which is, again, when you're looking at your data. We've developed inpatient cardiovascular service teams. And our teams will see people in the ER before the ER doctor. And we'll say, go home or get to the clinic, or can we send you over to the office? Our heart failure clinic has a 4% readmission rate. 4% because of the team-based care. But these doctors become expensive doctors because they meet the patient in the ER. Any hospitalization is attributed to their cost in the data assessment. Who's an expensive doctor, who's not an expensive doctor, but they're meeting the patient at the high cost event, but then they get them out faster, they transition them, they have all the metrics, and like, you gotta get these doctors out. I'm like, that's our hospitalists in the cardiac space. Their length of stays down 3 days, your cost structure. So what I'm basically saying is that some of the models we use, quality metrics, line of sight for cost of who those providers are, fall apart with some of the new delivery models. And I truly think it's this team-based care around disease management, supporting primary care, around protocols is, at least in our area, that catchment area. So hopefully, again, hopefully that gives some perspective, perspective on some of this.
So Peter, in your sort of following of what some of these big companies are doing, how much the Walmarts, et cetera, how much do you hear and see or read about whether they're pursuing health equity as a component of their breaking the cost curve?
Well, I think it's primary objective of all of the big companies because of the CMS intent, which is to address social determinants of health and to have a more equitable healthcare system for the country. And I think that what we see is people like Walmart and most of the population, I think, is no more than 5 or 10 minutes from a Walmart. So we're going to see a tremendous shift. And Walmart's already working to develop the and this is where the value-based enterprise becomes so important, is that for the first time, we're going to be able to have the creation of the teams that Dr. Fialkow talked about. We're going to see those teams move more into the social determinants of healthcare and to be able to address team health from that broader perspective of equity. And it's all going to be driven by the analytics that help refine by the risk codes, who is it that needs to be in a lipid program? Who is it that needs to be in a type 2 diabetic program? Who is it that needs to be in some sort of rehab for orthopedic type program? So I think we're going to see these equity challenged that way. And to get a better grasp of it and the role of analytics, I would point to a company called Centene, which is the largest Medicaid plan operator in the country. And Centene understands that they have to fix the social determinants of healthcare of a Medicaid population, which is acknowledged as being a little more difficult to manage. That's, I think, a nice way to say it. And what Centene did is they dumped their CEO about 8 months ago, and they brought in a new CEO. Let's look at the background of that CEO, because it tells us the importance of what's going to happen next. That CEO is 40 years old. Ooh, young. For CEO of a probably the third biggest payer plan in the country. 40 years old. And where did the CEO come from? An analytics company, Optum. 40 years old from Optum. And the CEO is a female. Bravo for that one. So it's the kind of forward thinking to address the problem that it's the analytics capabilities in the hands of people that can apply it from a total broad enterprise perspective. There are great people with analytics that can apply it in a narrow area, but where we're going to see the future of equity addressed is by the analytics as it's applied to an enterprise.
Can I follow up?
Sure, please do.
When I would look at the CVS Minute Clinics and the Walmarts and whatever, I think we agree, it's not that they're giving you the flu shot, it's the data they're acquiring to allow them to manage populations going forward in the next models. Do you see, I mean, to me, I see disease management, let's put it that way, as the biggest opportunity in the value-based space, right? So if we manage these patients with diseases, we identify them, we optimize them, we treat them, then you won't have the MIs, you won't have the heart failure admissions, you won't have the deterioration in their hips if we help them lose weight. So do you guys see that as an emphasis, as an opportunity? In other words, it's not just come to my office on Sunday night and don't go to the hospital. It's getting the data on these populations to manage.
It's absolutely what's behind driving the whole thing. And that's where the opportunity is. And I think, again, Centene, which, you know, the Medicaid pays about $267 per member per month in Florida. I think it's 267, 287, something like that. So when we talk about in the dual eligibles, which is Medicaid and Medicare, that's over $2,000. Those are very complex people, but there's an opportunity there to manage those people. And CVS, Walgreens, and Walmart see that they can get those people to their establishment, and using the team care concept where you have a physician and a team, that care team around the care plan can begin to address and manage that case much more cost effectively. And so the opportunity to make money, which is why they're doing it, is to be able to reap the benefits and bring them home in terms of much lower costs through better management and outcomes.
I mean, and I guess I would say from an independent practice perspective, you know, I think the boogeyman of CVS coming, you know, has been, I mean, we've been talking about that for a decade, I think. And, you know, while that's obviously progressed, you know, quite recently with Signify and all of that, there's still an issue of market consolidation, which I think is probably the biggest, you know, issue when it comes down to even the way that CMS issues benchmarks, right? If you have a consolidated market, you're competing against yourself practically. And that's kind of what happens at the tail end of this in a sort of exaggerated way. So market non-consolidation is actually incredibly important. And I think the way that you pit market forces against each other, constantly trying to race to find levels of innovation is not a blanket approach, at least in our experience. I think when we look at each practice, how they ultimately provision healthcare to their patients is very unique. Obviously, physicians are trained and emboldened to be unique, obviously diagnosticians, right? They obviously apply what they feel is the best sort of clinical method forward. And I think trying to put them all together in sort of a CVS bucket of minute clinics doesn't really kind of speak to sort of independent physicians quite well. But I also don't necessarily think it fits really well with the culture of Medicare fee-for-service patients. I think they look at consolidated choice, I think psychologically problematically. So I think when you're looking at a market that has the opportunity to be innovative, I wouldn't recommend us folding into the Walmarts or the CVSs because just simply the benchmarking doesn't work like that.
I'd like to just say something really quickly, and I know we're running out of time, but you were talking about, John, that everybody was preaching something terrible that was all going to change 12 years ago, and it really hasn't. But in reality, it has. It's just a massive change. I wrote this article, this PowerPoint 12 years ago. It is entitled Accountable Care and Clinical Integration and Evolution in Healthcare Delivery. But if you think about it, in 2010, Walgreens and CVS, other than delivering prescription drugs, being in the pharmaceutical business, they didn't care about healthcare. And all these mergers that have happened, these companies were all separate, running separate and apart. Now they're all merging together. And the truth is, it just takes a tremendously long time to change the entire healthcare industry in the United States. In fact, it may never get fully changed, but things have been happening more and more and more.
Yeah, I'm agreeing with you. I'm saying from the line of sight of the health system leaders, they haven't seen their margins drop.
No, that's true.
They haven't seen their volumes drop. No one's dropping their prices of their fee-for-service contracts, which enables them to be blinded to that. A presentation I'm putting together to the executives, for example, and I'll use some real numbers. Baptist does about $5.2 billion a year in revenue. And we did some reports, and about $2 billion of that is from patients who are in a value-based agreement. So Baptist doesn't get paid in a line item, they're fee-for-service, but those patients, someone is managing them. And if they were managed a little bit more strongly, that might put a little pressure on Baptist. They don't tell our patients, we don't get any money from value. Yeah, but the patients are, someone is in about a little more than 30 of your patients, and that's gonna grow. So, trying to bring that line of sight, but they just have not, our new CEO is on a record, 30 years, great guy. No, we're not really gonna get into that. Maybe send a call. Gotta figure out what I'm doing there, but at the same time, it's happening. He doesn't even realize what's happening in his own space. And I don't mean that in a bad way, just we do a lot of work, but that's what I meant by it, Mike.
Yeah, when I was writing about the stuff,
the dire warnings have not hit them in a way.
when I was writing about the stuff 12 years ago, I was quoting Bob Dylan, the times they are changing, but it's taken a little extra time.
By the way, if you had one anecdote, the anecdote I told you about the meeting with the lipid management program, the CMO was on the call and we've met. He wants us to build a lipid management program for the whole state for their payers and stuff. So there's some, buying in for those team-based approach. And the primary care groups in our area are starting to buy in also because the patients get managed, optimized, and sent back. So I do want to put that on the record.
Well, we're getting close to running out of time. For the CLE, the two phrases or two words are hybrid and enterprise. And I guess I wanted to ask one more question of Jonathan if we're out of time, but does your hospital system, and we've heard this from some hospitals, have any trepidation about value-based contracting with the No Surprise Act and what you're reporting in terms of your rates? And because
yes, and it hasn't had, and I we're all seeing that it hasn't, the consumer and the customer is not really looking at, it has made an impact.
Because all of the, I mean, I think from talking to Christine and her system that she was with, they would just report the top charge. But really, in reality, when
It's
you're,
such a complex way that most people.
yeah, but when you're looking at all the value-based arrangements and there's risk and partial risk and all that, it is, you know, there's different prices for everything and it flows with the amount of risk.
Concerns, it has not had an impact, and I'm expecting it to now. Some issues with our contracted specialty roofs, but again, I don't want to be a contrarian, because I think these things are important. We just haven't really, they haven't had an impact like we wanted to.
Well, thank you very much. And thank you for the panel and another good session.